choose class 2 cases. Why do you think we need to focus on class 2? I consider it emergency treatment. Because you don't like to see something like this in your practice, or like this. Or maybe dilated tooth. All of that because of trauma. So for me, class 2, it's emergency treatment. And if you don't treat that increased overjet, the patient will have permanent loss in their smile. Nothing in dentistry will replace that broken part of the tooth or even missing teeth. All of these, they are class 2 and they lost part of their dentition and the smile because of the trauma, because of the increased overjet. So for me, class 2 is emergency treatment, and I don't want to see my patients with that amount of loss. So if you have, let's say, a waiting list, I'll put the class 2 with increased overjet as top priority in my practice. In other patients, they may even have a valve teeth. So that patient, we needed to reinsert the central because of the trauma. So we are afraid from trauma. But again, I need to draw a line. So that line will help you to know if this is urgent treatment or not urgent treatment. So for me, it's the overjet. So if the overjet is 6 millimeter and more, it's emergency treatment and should be treated as soon as possible. If it is less than 6, I can wait. I will do my best to push most of my cases till the age of 16. But if the overjet is 6 millimeter or more, no, I need to treat them as soon as possible. So going back, this is one of the challenges in ortho treatment, the timing, always the timing. So in class 2, it's easy. It depends on the overjet of your patients. If any patient asks you, doctor, when should I bring my, let's say, children to you as treatment? When should we start the ortho treatment? This is open question. When should we start the ortho treatment? What will be the answer? To start with the group 1. When should we start? Forget about the class 2. If this is already questioned by parents, when should we start? What's the best time to start ortho treatment? Use your fingers. You can answer by your fingers. It's fine, okay? You will have another question, don't worry, okay? So, when should we start the ortho treatment? This is already a question. Give me an answer. Okay, should I shift to the next group? Okay. When should we start the ortho treatment? When they have the permanent teeth from 7 to 7. But again, this means, give me age. People, they will not understand that. After 6? 16 years, you mean? So you will put braces at the age of 6, you mean? So this is the question of the parents. When should we do the treatment? So you don't. I will help you. I will help you. If you start giving them the timing, this is wrong. But at the same time, I want to have the children in my practice at early stages. So you will tell them that there is timing for the first consultation and there is timing for the treatment. So by this, you will have all the children in your practice and the parents will not remember the age of 12 or 16, they will remember that they should bring their children for me at the age of 9. Because before the age of 9, you don't have the upper laterals. So you will not be able to judge the occlusion. So the ideal time for me in my practice is the age of 9. What happens if they insisted to have consultation before the age of 9? We have our colleagues, pediatric dentistry. So you can refer them to our colleague who will do the needed examination, and he will decide if he is going to do interceptive orthodontic treatment. But for me, I want to have the consultation at the age of 9. If the overgrowth is fine, and I don't have impacted teeth, and I don't have frostbite, I'll keep that child under observation till the age of 16. So I'll do my best to move most of my patients at the age of 16, except if they have increased overjet, or frostbite, or impacted teeth. These are the 3 conditions in which I can start early. If not, I will delay the treatment till the age of 16. Why I'm doing that? Why I'm pushing my patients till the age of 16? But remember, in the class 2 cases, the overjet should be less than 6 millimeters, because I'm afraid from the trauma. What are the benefits if you push your cases till the age of 16? Number 1, you agree with me, we need 7. So I want to want 7, so 7 will be erupted. Number 2, I want to monitor the parafunctional habits. Leisure breathing, lip seal, normal swallowing, teeth eruption, chewing fibrous food, healthy lifestyle, all of that I needed. Number 3, in severe malocclusions, you need to decide about age. So at the age of 16, I can decide about wisdom teeth. Number 4, I need to see the face symmetry, and you will notice this with me today, that you need to evaluate the face symmetry and to correct any canting. And you will not be able to see that before the age of 16. Number 5, in some malocclusions like Olombite, gummy smile, Bimax, mainly Bimax, the malocclusion will be reduced with time. So your judge about the case will be different. And finally, you agree with me that the patient complains, and you remember the lecture of yesterday about white lesions. All of that because we started early. That's why do your best to push most of your cases till the age of 16. By this, your treatment they will be successful. Have you seen any white lesions in my cases? Or gingivitis? I have some bad oral hygiene, but if you push your cases till the age of 16, you like what you are doing. So this is my personal, let's say, way of doing the consultation and the treatment. And by the way, this is some sort of management. You don't need to treat every patient that comes to your practice. You need to do the needed filtration, but you need to build the system. So this is my system for consultation and management of malocclusions. Let's go back to class 2. Why do we have class 2? I found that the etiology in children is totally different from adults and young adults. So in children, mainly it's related to habits. So maybe you have problem with the upper lip. Or in the habits, you will have the problem with the tongue, or mouth breathing habit, or some sucking habit. How to treat class 2 in young children? I call it phase 1. And I'll do that treatment if the overjet is more than 6 millimeters. If it is less than 6 millimeters, only I will establish good habits. I'll keep that patient under observation. For any case, I need to put my aims or goals. Why I'm doing the treatment. And if you don't do that, the parents, they will asking you and they will be demanding. You didn't do that, you didn't do that, we don't see a smile, they are not aligned. And by this you lose your control on your cases. So you need to write down the aims of the treatment. So number one, why do we treat patients with increased overweight? Number one, of course, to protect the upper front teeth from any trauma. Number two, this will improve the self-esteem, the confidence of the children at that critical age. And number three, the good thing with J1 Ultima, the braces and the wires at that time will act as space maintainers and regainers. So you can open the space for erupting teeth, you can then maintain the space if needed for the canines. And number four, imagine if you guide the eruption of premolars in class 1. This will be great. And finally, I will tell the parents that your child will need phase 2 in the future, but it will be less challenging. And in my practice, the fees for phase 1 will be deducted from the fees from phase 2. To encourage the parents to do phase 1, which is more important. What's my philosophy or mechanics in phase 1? Again, the overjet is increased. It's a combination between early elastics, class 2 elastics from the upper central, using inclined anterior wide plane. So, for example, this is a 1 centimeter overjet case. Then the treatment is needed. There is trauma or let's say risk of trauma on the upper incisor. So I want to shift this bite to 2 millimeters in one session. By doing this, I'm adding my new programmers, inclined 1, with early class 2 elastics, 114 medium. So from day 1, I will shift that overjet from 1 centimeter to be almost 2 millimeters to protect the front teeth from any trauma. This will give you headgear effect on the maxilla and functional appliance effect on the mandible. And it's effective, very effective treatment. And again, the same appliance will act as a space maintainer and regainer. So all these photographs, they are at the bonding session. Let's have a case. This is Salma. She has skeletal class 2, increased overjet, weak upper lip, incomplete lips, multi-breathing habit, and she doesn't like her smile. She is 9 years old, and the overjet is more than 6 millimeters. So I need to treat her. If you go back to the X-ray, the upper incisors, they are not severely proclined. They are almost right in position, but they are protruded. She is not a cooperative child, and she has dental phobia, but I cannot leave her. I need to treat her. I tried the myobrace, but she was not cooperative. And every morning she has the risk to lose some of her front teeth. And if you check her panoramic X-ray, you can see that she has complicated dentition. She has congestion missing lower left 5, congestion missing upper right 5. And we need to plan this in the future. So, in the day of bonding, I couldn't bond both arches. I spent 1 hour just to convince her to put SSH. But I need to bond her front teeth to make them resilient, to protect them from any trauma. So I bonded only the upper arch. Because of her phobia from dentistry, Then after 2 weeks, I bonded the lower arch. She refused to put any rubber bands. Still, I'm getting her trust to the treatment. She liked the braces. She liked the body. She liked the appearance. So in her next visit, I applied the class 2 elastic. I'm using open coil spring to create space for upper premolars and canine. I'm proclining the upper incisors to give me more space for the mandible to fit in class 1. And in less than 1 year, I finished her case. So again, this is right circle view. One of the tips, you can use the tubes of 7 to be bonded on upper or lower second primary molars. The best attachment for me for primary molars, they are the tubes of 7. I bonded the lower arch later on. Now we are in the sessile wires. I'm applying my class 2 elastics. I'm using open coil spring in the upper, closed coil spring in the lower. One of them to regain space and the other one to maintain the space. And I'll do my best to do overcorrection. And this is hair occlusion at the end of the treatment. It shouldn't be idle occlusion. Go back to the goal or your aim. Your aim is to protect the teeth, to restore the overjet to be almost within normal range. The same for the left side. This is the view for the upper arch. The first day of bonding. And you will see the amount of arch development on the upper arch, even in primary teeth. So we corrected the inclination of upper incisors, and we have now very beautiful arch form in the upper arch. This will help her mandible to fit in class 1. For the lower arch, nothing special. And the most important thing is the overjet. So we shifted her overjet from almost 7 to 8 millimeters to be 4 millimeters. So now she is in the safe zone. So these are the intraoral photos for Salma, before and after. And the change was skeletal. So this is her profile in the lateral staff. All of that because of what? I mean, we didn't end with lingually tipped upper incisors, and the lower incisors almost they are with the same proclination. How we did that? Variable source. Procline upper, procline lower, deprogrammed with airlay elastics. Of course, we improved the airways for Salma. And what about the soft tissue? What about the lips? This is more important. I need to have the muscles with me, not against me. So let's see, never breathing is so important to stabilize your case. And you remember, she has exomotor lips, weak upper lip, inverted lower lip. Now she can see her lips. Of course, I needed to train her. Every visit, I will teach her how to pull the upper lip to reach the lower lip. Let's see, I call that training. By the way, I will share with you maybe 4 to 5 trainings or exercises to your patients. Number 1, lip seal exercise using the upper lip. Lip seal exercise using the upper lip, not the lower lip. All of the lower lip is hyperactive, but the upper lip is weak. So she can now bring the lips together. And for the smile, of course, she has now normal smile. She has amazing smile. So this is at the age of 10. Then I saw her later on at the age of 13. So this is her X-ray at the age of 13. And she lost that primary molar. That's why I gave her lower Essex retainer. And I used to replace that retainer every 6 months. because she is grown. So this is the end of phase 1. I kept her under throw-up, and she's improving. All of that because of the good habits. Lip seal, laser beam. And the same for the X-ray. We didn't lose what we have done. It was a stable result because of the soft tissue and because of the right torque for the upper and lower incisors. And these are the intraoral photos for Selma, and she's now 50 years old. And the upper jet even is improving. It was 4 millimeters at the end of the teeth. Now it's almost 3 because of the mandibular growth. Of course, I will push her till the age of 16. Because she will need phase 3 in the future, and we need to manage the space for future implants in the future. So yes, 1 year of treatment. Remember, she was not cooperative. She was not the right child, but variable torques, braces, wires, elastics, they are, for me, they are less complicated than removable function appliances. So you can use that to your patient. So this is for younger children. What about severe class 2 cases in adults and young adults? At first, what's the etiology behind class 2? If I will ask you, do you think the class 2 is anterior-posterior discrepancy? Do you think class 2 is anterior-posterior discrepancy? We used to do that, but from my experience, no. Class 2 is not anterior-posterior discrepancy. It is a transverse discrepancy. So most of your class 2 cases, they are transverse discrepancy. I mean, the upper arch is constricted. So the best system in the market that will give you arch development, the needed one is Demon Ultima. And it will be very simple. You don't need bands. You don't need expanders. And most of your class 2 cases, what about the upper canine? Are they proclined or normal or lingually tipped? Both of your class 2 cases. Lingually tipped. How to apply them? Are you going to do torque in the wire? Ultima will give you proclined torque. And that proclined torque will keep the roots away from cortical plate. So if you apply class 2 elastics, you will do crystallization. And some of my patients, the class 2 because of vertical discrepancy. I mean the maxillary excess will push the mandible back. That's why it's not anterior-posterior, it is transverse, and in some cases it's vertical. So it's about the maxilla. Class 2 is about the maxilla, and mandible is a follower, and most of your cases, the mandible size is normal. We don't have micrognathia in the mandible, it's retrognathia. The mandible is locked behind the upper incisors or canines or constricted upper arch. And you remember this diagram. This is the mandible in red color and the maxilla in the black color. So the shape of the maxilla maybe in some cases is retroclined upper incisors or anterior crowding. In other cases you have lingually fixed upper canine, and in most of your cases the maxilla is constricted. In normal persons this is what will happen, they will fit a class 1. But because the maxilla is constricted anteriorly, or lingually fixed canines, or the whole maxilla is constricted, this is what will happen. The mandible is locked. But the smart thing is how to do the arch development in the maxilla and how to procline the upper incisors or the upper canines if needed. That's why, for me, Demon Ultima is the best system to treat class 2 cases in a simple, efficient way. So the scenarios for class 2, in my practice, they are maybe because of lingually tilted upper incisors or severe anterior crowding, or maybe lingually tilted upper canine, or constricted upper arch, and in some cases it's vertical maxillary effect. So we'll take each one of them and we'll have a clinical case. And of course I did some mistakes, so you will learn from my mistakes. Of course I corrected these mistakes during the treatment. So let's do phase 2 now for some patients. So let's take the lingually tilted upper incisors or severe anterior crowding. Let's start with the crowding. Do you remember the routine case from yesterday? Her mandible is locked distally because of anterior crowding. So intraorally, she has severe anterior crowding. So that anterior crowding was behind that overjet. I know that it's not more than 6 millimeters, but once you release the crowding, her mandible will sit in plasma. And all of that was reflected on her profile. So if you like the profile, all of that because we release the crowding. But if you extract, you will not get this. And of course, we supported the mistakes because of the wide smile. So this is one of the etiologies. So if you have upper anterior crowding, maybe this is the reason behind the mandible. But sometimes, no, you have lingually tilted upper incisors like Mays or Remise. She has typically class 2. So her mandible, what do you think about this bony chin? Do you like it or not? Is part of the attractive face or not? Yes, but because her mandible is locked behind upper incisors, you will not see that chin. So we needed to correct the torque of the upper two centers. I need your help. We'll start with the middle group. What will be the torque for the upper two centers? What will be the torque? You are within the group, huh? What will be the torque for the upper two centers? This group. Okay. So thank you. So you are with them. Okay. So thank you so much. It will be Brookline torque. What will be the torque for the upper canine? Look at the upper canine. They are lingually tilted. I need to do what? Brookline them. What will be the torque for the upper lateral? They are, yeah, thank you so much. They are Brookline. And if you take 60, you will like their roots. So you don't need to combine them more. What about the lower incisors? This Brookline. Because I'm going to apply class to elastic. So this will be the torque selection for Remise. So the torque preparation is to prepare my case for class 2 elastics and to correct the wrong torque of the upper canines and center. So this is the day of bonding, and it was easy going case, and we finished her case in 1 year. I can go back if you like this or her. She doesn't take care of her oral hygiene. That's why I agree with my colleagues. Once you feel that they are not good in teeth brushing, and I'm done with phase 2. I mean, she is maybe, let's go back to her age. She's 14, so we finished her case and she is 15. So I don't need to finish her case in ideal, let's say, occlusion because of her oral hygiene. Maybe after the age of 16, we can decide if we need to do phase 3 because then you'll see her face, okay, and she started to develop canting in the smile. So she will need phase 3 in the future, but you can see with me the beautiful torque expression on the upper canines, upper laterals, upper incisors. So we shifted hair case from class 22 to ideal class 1 just by torque selection and early elastics, and it took 1 year. And you can see the beautiful outcome of the torque on the upper incisors. I didn't put fixed retainer on here because she has a lot of anterior fillings, and I want to give her a chance to do flossing and to do maintenance in the future. Of course, I give her modified E6 retainer. You will see that retainer later on. And for the lower arch, as I have said, always the lower arch is good in most of your cases. So mandible is up lower. We bonded the lower fixed retainer from 4 to 4. And if you check her brachial X-ray, this is her X-ray in the detailing session when we did the revision for the bracket positioning. We did the revision for some brackets, and this is her X-ray at the end, and you can see with me the old fillings on the upper incisors. And for the overjet photograph, to get stable result in a class of 2, what you need to do with the interincisal angle? Are you going to increase the interincisal angle or decrease the interincisal angle? To have stable result in deep bite cases, you need to end with reduced interincisal angle, and you will have that because of the procline torque of upper incisors. And this is her retainer. So I added in the front part of that retainer inclined plane. So that inclined plane will prevent any deepening of the bite. We'll see that in another clinical case. So this is the lock of the deprogrammer. So she will bite on that deprogrammer, and that deprogrammer will force her to bite in class 1. So this is some sort of active retention. And this is her lateral side before and after. What do you think about the interincisal angle now? It's ideal. So it will be stable result. And you can see with me the beauty of her bony chin. She has attractive chin. And for the smile, we ended with wide smile, but you can see with me now the canting, because she's developing facial asymmetry. The right is bigger than the left side, and she will develop more of the canting. So later on, I will evaluate her canting to see the need of phase 3 to correct that canting. So it was easy, successful treatment because of the right diagnosis and the right torque selection and the right persistent propagation system with early elastics. But in some cases, you may have lingually tilted upper incisors, but at the same time, you have lingually tilted lower incisors. Like Tala case. We'll start now discussing the face symmetry. Do you think Tala has symmetrical or asymmetrical face? We'll go to the fourth group now. So this is Tala. Do you think she has symmetrical or asymmetrical face? I know that at the age of 15 it's difficult, but how to evaluate the face symmetry? If this is your case, by doing what? Some doctors will do vertical line, but no, sometimes the eye is bigger, even on the smaller side. Sometimes the nostrils, you have central deviation. So this is my way of doing evaluation of the face symmetry. I call it face perimeter. So what I'm going to do, I'll take a point in the middle of the forehead, and I will follow the hairline till the chin on the left side. Then I'll do the same on the right side. Then I will see which one is longer. If you do that, which one of the face perimeter is longer? The right side or the left side? Draw imaginary line on the right side and on the left side. Which one is longer? The right. The right. That's why she has canting. More on the right. That canting not because of her teeth, because of the face asymmetry. You will not see that at the consultation session. When you are going to see that, once you reach the detailing session, once you put the braces, and you put your fourth wire, and take a smile photograph, she will show the canting. They will blame you. You did that for me. I was okay. I was the most beautiful girl in Jordan, and your braces did that distortion in my face. So you need to address the face asymmetry from day one, and write down plus minus one tad if needed on the affected side. If you check the lower incisors, they are retroclined. So upper incisor is retroclined, lower incisor is retroclined, and she has complete overbite. She has traumatic overbite. The lower incisors, they are touching the palatal mucosa. So if this is your case, tomorrow, how to fix that malocclusion? Do you have any system in the market that can procline the lower incisors? No? She doesn't have anterior crowding, by the way. So if she has anterior crowding, that crowding will help you to do proclination. But she doesn't have anterior crowding in the lower arch. And if you check her overjet view, so the lower incisors, they are reclined. Do you have any system in the market that can do proclination for both arches? The only system is Damon Ultima. So this is her overbite. So I'll go for the fourth group. Anyway. Okay. So I need your help. What will be the torque for the upper incisors? Yeah, thank you so much. You should include Maggie with you as society. And what will be the torque for the lower incisors? The question is for this group. What will be the torque for the lower incisors? You remember the question yesterday? What's the specific torque for each malocclusion? I told you it depends on the scenario. So I need from you to grasp the philosophy, not only to memorize the colors. I want to imagine the action. What do you want to happen for the lower incisors? I want to procline them. That's why the torque will be procline torque. So this is the torque selection for the same patient. So it will be procline torque, upper and lower. And I put my deprogrammers on the upper canines. You can put them on lower sevens, but this is not enough because she has complete overbite, and the upper incisors, they will touch the brackets. So the best location of the deprogrammers in her case They are the upper canines. So this is the day of bonding. I'm not using class 2 elastics in hair case to do anterior correction, but I want to do extrusion of the molars and premolars to correct the deep curved speed, while I'm holding hair bite anteriorly with deeper grammars. But don't forget where I put the brackets on the centers. What do you think is the position of the brackets on the centers? 5.5. So I will not intrude the upper incisors. I want to protect her smile arc. Still we are in the flexible wires. You remember we had canting. That's why I added one tab on the upper right side to do differential impaction to correct the canting. But we are in the cell C wire. And we finish hair case in IDA class 1. I need from you to follow the inclination of upper canines. Do you see the change in the upper canines? Big change. All of that will affect the face and the smile and the body. And now we can see almost more than 2/3 of the lower incisors. Did we use any intrusive mechanics or Perston or utility arch? We don't need to do any wire bending. Don't do wire bending, by the way. If you don't like the position of the tooth, change the bracket position. Faster and better and less unwanted forces. So this is her right buccal view. This is the day of bonding. You can see the amount of deep curve speed. I'm doing differential impaction on the right side to correct hair smile, and we finish hair case in IDA class 1. So it was simple, easy, efficient way, and it should be reflected on the face and the smile. You'll see that later on. If you have rotated teeth, don't bond the expensive Ultima bracket. Put bottom first. Then bond your bracket. I'm talking about the upper left 5. Yesterday I told you that with Deon Ultima, even if you apply very light elastics, even I put figure 8, teeth, they are easy to be moved with elastics. So you will have accidental spacing. Do you see that space? Medial to upper canine. I put figure 8 to prevent any spacing, but you don't have friction. So we had that headgear effect, but it was accidental in her case. So I needed to close that space. And this is the shape of my debograms on upper canines. I will keep them till the session of detailing session. So once you insert your 4th wire, I will remove the debograms to make my case ready for the panorama. You see that space? Medial to upper canine? You will see it in most of your cases. And I need your help, Dr. Annie. Most of your last 2 cases, the canines, they are what? They are lingually tilted. Where are the roots? Touching cortical plate. What do you call this? You say, Annie. What do you call this if the roots are touching cortical plate? Cortical bone anchorage. So if you keep these roots touching the cortical plate, even if you spend years doing class 2 elastics, nothing will happen. The canine will not move. On the other hand, because we procline the upper canine using procline torque, the roots, they are away from cortical plate, they are in medullary bone, so just light elastics can give you that space. You can see the labial surface of her lower incisors. If you take photograph for class 2 cases, I mean closer view, you will not see the labial surface of your lower incisors. But the lower incisors, you can see the labial surface because they are intertwined. So follow the torque expression on the lower incisors. Follow the torque expression. And I did IPR. So you will like their alignment and their position now. And the same for the overjet. We are proclining the upper and lower incisors while we are correcting the deep curve speed, while we are creating wide connectors, we are correcting the canting, and this is her final lateral or overjet photograph. You will see the same on her X-ray. By the way, I used to take my lateral staff at the same day of debonding. So I used to do overcorrection in class 2 cases. So this is overcorrection. After 1 week, what will happen? We'll have rebound. So she will bite in the normal bite. So do your best in a class 2 cases to do overcorrection. For example, issue bite, and within 1 week, maximum 1 month, the bite will sit there. And for the profile, she had hypermasseteric muscle with deep bite, and now we restore the lower facial third. So her face is relaxed now. And we restore the lower facial third. I mean, we increase the lower facial third in her case. And you can see the change in the chin position and the jawline. And for the smile, you remember, she had canting. Do you see any canting? We'll take the upper lip while smiling. So we added 1 tad to correct the canting. But are you happy with her smile? By the way, this is so important. And all of you have the same problem. We'll take the first group. Are you happy with her smile at the end of the treatment? When I say smile, it is teeth and muscles. So maybe you are happy with the teeth. But are you happy with the muscles? Do you think she is smiling? Are these the muscles of smiling? What do you think? Who has any comment about the muscular action after ortho treatment in smiling photograph? Do you have any feedback? Smiling is complicated, high-end human being action. Everything is working, including the subconscious brain. So she is laughing from her heart, but the subconscious brain after ortho treatment, because it's a new smile for her, will tell Tala, your teeth, they are not beautiful, so you need to hide your teeth. So she is smiling and hiding the smile at the same time. That's why her muscles, they are turning down. Her teeth, they are great, but the muscles, they are turning down, trying to hide the smile. I'll give her a training, an exercise. I call it smiling exercise. So we have the first training, lip seal using the upper lip. The second training is a smiling exercise. Tala, Show off your smile. Your teeth, they look great. Keep looking at the mirror. And she will start having positive feedback from others. So this is her smiling photograph after 6 months. Same teeth, same occlusion, same patient, same camera. So do you see the amount of change in the smile? Why? Because now the subconscious brain started its job. You have a great smile, Tara. So please, let's activate the elevation muscles of the face. So the corners will go up. They were going down here. So the muscles, they are going down, hiding her teeth. Now they are going up. So if you like your result, but you don't like the smiling of the patient, you need to teach them how to smile. Later on, we'll do whitening for hair case. So whitening is part of the finishing. Don't forget, we corrected the canting. Do you notice any face asymmetry now? Remember triangular symmetry. So if you take the upper lip while smiling as your reference, and you fix everything below the nose to be symmetrical and in proportion, this will hide the face asymmetry. Her right eye is higher than the left eye. And her right side of the face is still bigger than the left side of the face. But you will not notice that, because your eyes, as a human being, will follow lines and curves. You are not following shapes. You need to follow some geometry. And the geometry in the face is the upper lip, the smile arm, and the lower lip, with the white connectors between the teeth. So if you do that in the right way, you will like the outcome of your cases. So, we were covering the etiology of class 2 in adults. So we covered lingually tilted upper incisors, we covered anterior crowding, we covered lingually tilted upper incisors and lower incisors. We know now how to evaluate the face symmetry. We can correct the canting, and we know how to pick the torque depending on the malocclusion. What about lingually tilted upper canines? I think the T break or coffee break will be at 10. Who is the moderator? Should I finish at 10 or 10? Okay, that's great. So most of your classroom cases, they have lingually tilted upper canines and you have proclamator. So let's take adult case. This is Lean. She's 22 years old, and she has lingually tilted upper canines. But at the same time, do we have canting or not in her smile? We have canting. We have gum smile. So we need to treat the gum smile. We need to treat the canting, and we need to unlock her mandible. But before treating her, let's take another example in which we don't have procline torque, and to see the effect of class 2 elastics on such cases. So let's take another case, very close in terms of X-ray, like Lean, and she has almost lingually tilted canines, mainly the upper left canine. This is Farah. And I treated her using insignia. So in insignia, the torque is neutral. So in such cases, by the way, this is the wrong case, okay? So don't take photographs. But I want to show you the bad aspect of neutral torque. In insignia, they bought the brackets at 4 millimeter, not 5.5, and the torque is neutral. And she has unilateral class 2 on the right side. So I applied class 2 elastics only on the right side. And what will happen for the closer plane in class 2 mechanics? If you put class 2 elastics, this is what will happen. If you don't have applying torque. That's why we did canting now. And we have more gummy smile. So in your practice, if you have canting during the teaching, or you have gummy smile, this is because of the class 2 elastics. But this is because of the, maybe you are not picking the applying torque. So in our profession, maybe you are inducing gummy smile and we don't know. So in her case, I needed to add 2 tabs. Remember yesterday when I talked to you about the 3 challenges every morning: tongue, growth, unwanted forces. So this is the result of unwanted forces. So I needed tabs to correct the canting, and we finished her case. So I needed tabs in her case. And we restored the right interincisor angle. But I didn't see big change in her profile. Again, this was insignia case. So this is her smiling photograph at the start. Once we lost the control, and I needed tabs in her case to correct that canting. Then later on, we did whitening for her case. Sorry, I should put that photograph in the front. We achieved this, but with the help of tags. On the other hand, by the way, this is the same patient in which I did soft tissue contouring and hard tissue contouring. And her age during the thesis, it was 19 years old. You want me to go back? Yeah. So we needed to do hard tissue, soft tissue, and we added that, then whitening. But if you have variable torques, you can treat the same case without the need of that. So again, let's go back to our patient lean. Her smile, I mean lean, with canting, with gummy smile, very close to the smile of Farah with canting because of my class 2 elastics, and also she has gummy smile, but she has short clinical crowns. In Farah case, we put the brackets at 4 millimeters. In Lin case, we put the brackets at what? Where should we put the brackets on Lin? Where are we going to put the brackets on the center? Okay. So imagine in Lin case, we'll put the brackets at 5.5, and I'll spend 1 year doing class 2 elastics, and I will not need tags. And she's already in gummy smile. I want you to compare the 2 cases to see the power of the Brookline torque. These are the intraoral photos for Lin, and they are very close to the other patient. And this is the torque selection for Lin. If you are going to change anything in that torque selection, what's the wrong part of that torque? except the middle group. If you want to change anything of that sort, what will be your change or your add or your correction? No, not the upper arch. Something in the lower arch. In class 2 cases, I used to put Brookline torque with Gemini QQ2. But again, the torque selection in your cases is for the face. So if you put Brookline torque on lower canines, this will prevent you from putting your mandible in more class 1. That's why if you put neutral torque, this will give you more chance to put the mandible in more forward position. So you need to do that for the face. So this is the day of bonding. I will not put elastics because we have almost no more overjet and we don't have too much of the class 2 myocclusion. So once we apply the upper anterior segment, we'll start our class 2 elastics, and you will see later on the headgear effect of the class 2 elastics. Remember, we put the brackets at 5. She came to us with canted gummy smile, and I spent 1 year, more than 1 year, putting class 2 elastics. And we'll see at the end her smiling photograph. So this is her final frontal view. We put the brackets at 5.5, but the torque was Brookline torque. With Demon Ultima, always you will have good amount of space, mesial to your upper canines. Now I will use that space to do refraction, but to the left, because she has midline shifting. I call it asymmetric refraction to the left. We call this headgear effect of the Demon system. All of that because of low friction and because of the torque expression. Now she's in class 1. Nothing special in the upper. But you can see with me the space mesial to upper left canine. So this is before asymmetrical retraction to the left, and this is after. Before, after. I like to have my anterior teeth as one group to do the leaded retraction. Again, the lower arch only minimal crowding. And for the overjet, you follow the overjet photograph in the above row. The upper incisors, they were interplined. We are proclining them, but we are doing class 2 elastics with retraction. Class 2 elastics with retraction. So if you are using insignia or other torque, you will end with more lingually tipped upper incisors. But this is her case before, and this is her case after. What do you see? Even we spent 1 year doing class 2 elastics. They are proclined. So always if you put a proclined torque, the position of your incisors will change in a 3D. I mean anterior posterior and vertical one. So proclined torque will do some sort of intrusion of your incisors. So if you follow the line, if you pick proclined torque, the red one, you are moving your tooth up. So this is hair X-ray before and after, and this is your occlusal plane. And we spent 1 year doing class 2 elastics. But if you check the upper incisors, almost they are slightly intruded. So this is the bore of the proclined torque, and her mandible was locked. Now it is unlocked. So we improved the profile. Even if you look at her frontal view, you can see with me the jawline. We restored the balance for the face. And for the spinal photograph, I need from all of you to remember the following. I put the brackets at 5.5, not 4. And we didn't use any tags. And I spent 1 year doing class 2 elastics. But this is the outcome. Even the canting was corrected. All of that because of the power of the propline torque. So the propline torque will help you to treat gum smile cases if the etiology is lingually tilted upper incisors. So this is the power of the propline torque. So it's very effective, very effective. I needed to do soft tissue contouring, but mainly on the upper laterals and premolar area. But for the centrals, already the incisor show was, the crown length was normal. So the propline torque will change the teeth position in 3D. So it will propline and it will intrude. And you need all of that to control the unwanted forces of the class 2 elastics. Most of your class 2 cases, they will be the constructed upper arch. So this is ayat, and her overjet is how much? 1 centimeter. Increase overjet. For some doctors, it should be extraction case, but no. Again, the etiology. It's about constructed upper arch. So this is her upper arch. It is constructed. So that construction will prevent the lower arch from fitting in class 1. She has retained primary T9. So I decided to do the bonding and the extraction at the same day. Imagine consultation, bonding, and extraction same day. And this is what we have done for Ayat. But before that, her upper incisors, already they are propline. And I don't have spacing. So I don't want to do more proclination or even to keep them. I want to lose the torque of the upper incisors to improve the smile aesthetics. So again, this is her panoramic X-ray. So at the day of bonding, before that, this is the explanation why do we have class 2 in such cases. So this is another case, but if you trace the upper arch and if you trace the lower arch, most of the class 2 cases, they will not fit because of the construction of the upper arch. So you need to do arch development and the lower arch will fit in class 1. That's why we have increased overjet. So we bonded her case to do arch development for the upper arch using Diamond system. I didn't pick propline torque for the 2 centrals because already they are propline. So I picked a neutron torque. If I'm going to change anything, it will be the torque for the lower canal. Remember, the overjet was 1 centimeter. So I need to apply class 2 elastics from day 1. But I don't have the key 9 on the right side. But it's fine because each ultima bracket they have vertical stop. And you can use the drop-in hooks of Q2. So if you want to buy the drop-in hooks for Diamond Ultima, they are the same hooks for Diamond Q2, not the Q1, Q2. So we added these 2 hooks for the upper force. to apply short class of elastics. The overjet is 1 centimeter. It was impossible for me to put my deep-grammer on the upper two centers. They were on the lower sixes. This is her first follow-up visit. In her third follow-up visit, I inserted my first Altiba wire, which is 14 by 0.75. But in that visit, I removed the deep-grammers from lower sixes and I added them on the upper two centers because the overjet was 5 millimeters. So I can put my deep-grammer on the upper two centers. Now we are in the thirsty wire. And we finished her case in 1 year. So it was easy, faster treatment, without any complications, because of the torque selection and the early elastics and the decogrammers. So I bonded the case, I took the photograph, and that bluish discoloration, this is the anesthesia. So once I took that photograph, I extracted the retained upper primary canine on the right side. In her third visit, this is her bite, I shifted my deep-grammer from lower sixes to be on the upper two centrals, to shift her bite from 5 millimeter overjet to be 2 millimeter overjet. Now we are in the finishing the wires. And this is her right buccal view, again with some overcorrection. This is the left side. Again, you can put your dribble hooks on the premolars if you want. Remember, the upper arch was constructed. And this is her in the third visit. I removed the decogrammers from lower sixes and I bonded them on the upper two centers. So I'm going to combine my anterior degrommer with the class 2 elastics. So by this you can forward the mandible more. Now we have wide upper arch. So that wide upper arch can accommodate the normal mandible. So at first I put my degrams on lower sixes, then in the third follow-up visit, I removed them and I put them on the centers. You remember the overjet, it was 1 centimeter, big overjet. This is the day of bonding with early elastics. I shifted degrams to be on the centrals. Now we are in the finishing wires, and now we have the right overjet with the right inclination. And the change was obvious on her face. So it was big change on her skeletal pattern. So all of that because of the right torque selection, deep grammars with early elastics. It took from us almost 1 year. Of course, this was reflected on her profile, and this was reflected on her smile. So, if you have constructed the upper arch, Devon Ultima will give you the needed power, I mean shoulder to wall, kicking effect to widen your upper arch. So that upper arch will be more than happy to accommodate the lower arch. In other cases, maybe you have increased overjet, but you have increased over pressure third, you have tongue distrust, you have canting, and that patient, she was treated in Riyadh first, in Saudi Arabia, and they put expander on the upper arch instead of arch wire. And she came to me for consultation, so of course I will treat her, but you can see with me the face asymmetry. The left side of the face is bigger than the right side of the face, and she has canting. And do you see the shadow of the tongue? She has anterior tongue thrust, and she has increased overjet. Or she has an expander, and she has shorter chin to floor distance, so she has convex profile. These are the intraoral photos for Maya, and this is too much force. We don't need it. This is heavy forces. That's why I removed that expander, and I bonded hair case to improve the face aesthetics and the smile aesthetics. So this is the day of bonding. And if I'm going to change anything in that torque selection, what will be your put or your add to that torque? If this is your case. Again, lower canines. So again, she's traveling all the way from Riyadh to Jordan. And I used to put procline torque when I was using the Q2 for lower canines. But the torque exhibition with Ultima is more. That's why that too much proclination of lower canine will prevent me to fit hair manually in class 1. And you will see that with me now. But I changed it in her last visit. And she asked me to finish her case in 1 year, by the way. And she was planning to visit the country, I mean Jordan, only 4 times. So I need in each follow-up visit that will take 1 week, 10 days in each vacation, I need to put 2 wires. So I bought in her case, and by the way, this is her bite, and you can see the tongue. So this is the lingual freedom of her tongue. So her tongue was a very strong one. And I added the grams on lower 7s, and she has now open bite. And now it's time to talk about the third exercise. So we talked about lip seal using the upper lip. We talked about smiling exercise. And now I need her to do something I call it conscious swallowing exercise. I will ask Maya, bite with your back teeth. While you are biting, do lip seal and swallow while you are in the maximum intercuspation. Try to do it, all of you, even myself. Maximum intercuspation and swallow. This will force your tongue to go back. It will not go to the front. Also, I added tongue famous on here. So in here, for the second follow-up visit, you see the change? The open bite will start closing because of the training. Then it's time to bond the lower left central. So this was in summer. At the beginning of winter, we needed to do a panorama. So this is her smiling photograph in the panorama. You see the canting now. So we needed to add 1 tab on the left side, and I needed to do revision for the 2 centers. So I did the revision for the 2 centers. And we added 1 tab on the left side to correct the canting. You can see the amount of differential induction on the left side. I'm applying class 2 elastics on the right side, box elastics on the left side because she has more of the class on the right side, and I want to have my lower midline to the left. In her next summer, I mean the time in which I needed to do debonding for her case, I had this idea that better you need to change the torque of lower canals of your cases to be neutral. So in that session, this was the inclination of the canine. So this is what I need. That bracket is a fresh one. It's a new one now. So the aim of the neutral torque is to do this. The same on the left side. This is the inclination of the canine. So the neutral torque will do this. So if you do that, what will happen for the anti-posterior correction will be easier. But it was too late because I needed to do debonding in 2 weeks before traveling back to Saudi Arabia. And of course, the torque expression will take time. So it was a learning curve for me. That's why still I'm not happy about the settling of occlusion, but she forced me to do debonding. So I gave her my brace, A1 medium, to settle the bite and to control the tongue. This is her right buccal view. She was with full into class 2 on the right side, anti-open bite. I gave her conscious swallowing exercise. So this is her bite at the day of bonding. You can see the tongue. So you have class 2 with open bite, with tongue thrust, with facial symmetry, and the round torques selection for lower canals. I asked her to do squeezing exercise or conscious swallowing exercise. We are doing bone modeling now. More bone modeling. We did the panorebo. I added one pad on the left side to do correction of the canting, since she's in class 2. I couldn't establish class 1 because of the propline torque on lower canines. So sometimes if you pick the wrong torque, this will complicate your mechanics. So the new things for me with Deon Ultima now in the class 2 cases, I need to put neutral torque on lower canines in that case. I gave her my brace to do some sort of overcorrection. The same on the left side. The only change was the tab on the left side to correct the occlusal canting. Remember, I finished her case in 4 visits, or you can say 4 visits to the country in 1 year. But we didn't need the expander. You don't need it because the sevens, they are in the right position. So they will give you the needed cornerstone to establish your arch form, and you will see that in her occlusal view. So it was a very nice arch development without the need of any expanders. For the lower arch, we needed to add 10 femurs. I will share with you today where to bond your 10 femurs on the lower arch or the upper arch. So this is my before the treatment with increase of jet more than 6 millimeter with anti-open bind and canting, and these are the intraoral photos. The end of the treatment. Still, she will need some sort of my brace as active retainer. But from let's say open bite, or you can say, yeah, he has almost edge-to-edge bite with anterior big gap between the upper and lower teeth with strong tongue. Now we have positive over bite and over jet. But the most important thing is this view. It's not easy to control the anterior discrepancy while you are having vertical discrepancy, but this is here over jet at the end of the treatment. So we improved the location of the mandible. Even I picked the wrong torque for lower canines. And for her profile, you can see with me now the jawline with improved profile. You can see in her facial features as a start of the treatment, This is her tongue, by the way. You see that bulge here? This is her tongue. So she has abnormal tongue position. Now she has normal tongue position, and we enhance the face aesthetics, and all of that in 1 year. Even if you look at the face, you remember she came to us with facial asymmetry. So the left side of the face was longer, so we did differential impaction. But now her face, you see that it's symmetrical. I did nothing for, let's say, the orbit or anything above the nose. We worked only on the triangle symmetry. So this is her smile at the start of the face with the canting, another smile, and this is the tracing of her canting, and the lower midline was tilted with her chin to the right. But if you do differential impactions, okay, you will get this. All of that because of one tad. So remember the triangle symmetry. So one tad was added on the left side to correct her closer canting. So yes, it's effective treatment. And remember the tone of the lower canal, one tad on the left side. And for the vertical magnetic excess, it will end with the class 2, but I will not treat these cases in this session. They are open bite cases or vertical maxillary excess cases. So we'll treat them with gum smile or with open bite malocclusions, because the correction will not be about class 2 elastics, it will be about vertical control. So in the first class 2 malocclusion, you have increased overjet. Overjet here, you will see it later on this evening. It's 8 millimeter, I mean the overjet, but it's related to posterior maxillary excess. So once you correct the open bite, you will have auto-rotation of the mandible. The other malocclusion is vertical maxillary excess, and you remember the case of Jumana. She has a convex profile, and you can consider her case is class 2. So we'll treat her case and the vertical maxillary excess cases. And by the way, she asked me to finish her case in 1 year before the wedding. So, time now for the coffee break, okay? Thank you so much for being with me for the last 90 minutes, okay?